What if I told you your DNA already contains a draft of your health future and AI can now read it? That's not a hypothetical anymore. Right now in my clinic, I sit down with patients and their whole genome sequence on a screen integrated with their blood biomarkers, body composition data, and fitness metrics. And an AI platform synthesizes it into a clinical picture that would have taken a team of specialists weeks to assemble even 10 years ago. I'm Dr. Trevor Turner. I'm a precision longevity physician at Pravida Health in Buckhead, Atlanta. And I've done a fellowship in precision medicine specifically because I believe this technology represents a genuine inflection point in how we prevent and manage disease. Today I'm going to show you exactly how it works, and I'm going to be honest about what it does do and what it doesn't do, where it has limits, and why the physician judgment layer still matters enormously. Let's start with a foundation. Most people who've done DNA testing have done SNP genotyping, services like 23andMe or Ancestry DNA. Those tests read a small fraction of your genome, somewhere between 600,000 and 2 million specific known variants. Think of it like reading every 10th word in a book. Whole genome sequencing reads the entire book, all 3.2 billion base pairs of your DNA. That's a completely different level of resolution. Instead of checking pre-identified positions, you're capturing everything. Rare variants, structural variants, regions of your genome that SNP arrays don't cover at all. And what does that actually tell you? Here's where I need to be precise because there's a lot of marketing language in this space. Your genome does not predict your future with certainty. What it does is it reveals your individual risk architecture, the genetic variants that raise or lower your probability of certain conditions, that determine how you metabolize medications, that influence your response to different nutrition strategies, and that shape your hormonal baseline. Think of it like this. Your genome is the hardware, your biomarkers, lifestyle environment, and epigenetics are the software. The hardware constrains what's possible, it doesn't write the story. So when someone says, I got my genome done and it didn't tell me anything actionable, it's often a sequencing and interpretation quality issue. The data is only as useful as the clinical framework you use to interpret it. At Pravida Health, we use Bioscope.ai as our primary genomic and health data integration platform. The core concept is a digital twin, a computational model of your biology built from your genomic data, integrated with your lab results, wearable data, body composition, and other inputs. Let me walk you through what the dashboard actually shows. First, you get a genomic risk stratification across major disease categories: cardiovascular, metabolic, neurologic, and oncological. This isn't simple, you have the gene for X. It's polygenic risk scoring, which aggregates the cumulative effect of hundreds of variants across a given pathway to generate a probability risk estimate. These scores are significantly more predictive than single gene analysis for most common chronic diseases. Second, pharmacogenomics. This section is often underappreciated by patients and critically important to me as a physician. Your genome determines how you metabolize most medications, which CYP450 enzymes you express at what level, which drug classes you're likely to respond to, which you're likely to metabolize too quickly or too slowly for therapeutic effect. Before I make any pharmacologic intervention, I want to know this data because it changes clinical decisions. Third, nutrigenomics. How your genetic variants affect your dietary requirements and responses. MTHFR status for methylation, ApoE genotype for fat metabolism and Alzheimer's risk, VDR variants for vitamin D utilization, TCF7L2 for carbohydrate metabolism. These variants directly inform nutrition and supplementation strategy. Fourth, and this is where the AI layer becomes most powerful, is pattern synthesis. Bioscope.ai's platform doesn't just surface individual variant findings. It integrates your genomic data with your current biomarkers and flags divergences. If your ApoB is elevated and your genome shows an ApoE4 variant and a PCSK9 gain-of-function mutation, that's a cardiovascular risk signal that has a specific aggressive management implication. The AI can identify the pattern across thousands of data points in seconds. This used to take a human geneticist hours. Let me give you concrete categories of insights that routinely change what I do clinically. I'm speaking in categories and not in individual cases, but these are the patterns that I see regularly. Cardiovascular risk that standard panels miss. A patient comes in with unremarkable standard lipids, but their genome shows elevated Lp(a) genetic risk confirmed by elevated measured Lp(a) in the blood. A risk factor that is almost entirely genetic is present in roughly 1 in 5 people and significantly elevates lifetime cardiovascular risk. Without the genomic context, this might not get the clinical attention it deserves. But with it, we're actively monitoring and managing. Medication selection and dosing. A patient on a common antidepressant who isn't responding. The CYP2D6 genotype shows that they're an ultra-rapid metabolizer and the drug clears their system before it ever reaches therapeutic levels. They were never non-responders to treatment. They were on the wrong dose for their metabolism. This is genuinely common. It's one of the clearest clinical applications of what we call pharmacogenomics. Nutrition. MTHFR compound heterozygous. This variant impairs the conversion of folate and B vitamins to their active methylated forms. Supplementing with standard folic acid does nothing essentially for this patient. You need methylfolate and methylcobalamin. This is not a nuance you'll find on a standard blood test. It's in the genome. Hormone baseline drivers. Variants in the androgen receptor, aromatase enzyme, and sex hormone binding globulin gene. These explain why two men with identical total testosterone can have very different physiologic experiences, and why one might need intervention at a level where the other is asymptomatic. Now, I want to address something directly because I think it matters for trust. AI is a clinical co-pilot. It is not a physician. Here's what I mean by that. The Bioscope.ai platform synthesizes data and reveals patterns. It does that extremely well, better than any human could at the same speed across the same data volume. But what it produces is an input from my clinical reasoning and not an output. Interpreting a genetic variant requires knowing the quality of the underlying study that characterized it. Risk scores require context. Your family history, your biomarkers, your lifestyle, your symptoms. The platform might flag a variant as high impact, but my job is to determine whether that flag is clinically relevant for this patient right now, given everything else I know about them. More importantly, the conversation matters. A patient's genomic risk for cardiovascular disease means very different things depending on whether they're 35 or 65, whether they smoke, whether they have a stressful job and poor sleep, or whether they have emotional bandwidth right now to make significant lifestyle changes. That context sensitivity, that is human judgment, and AI does not have it. What I tell patients is, the AI platform makes me a better doctor. It gives me a richer map of your biology that I could never construct manually, but I'm the one driving. The map is extraordinary, and the navigation still requires a human doctor. I get asked versions of this question regularly. Should I trust AI with my health data? Well, it's the right question to ask. And a few things I tell people. First, understand what the AI is doing with your data. At Pravida, your data is used to inform your care. Full stop. That's a significant difference between a clinical platform integrated into a physician practice and a consumer app that trains models based on your health information. Second, AI in medicine is not new. Radiologists have been using AI-assisted image reading for years. EKG interpretation algorithms have been in clinical use for decades, and we use them with our Cardia 12L handheld device. What's new is the scale, the multi-model integration in the genomics layer. But the principle, using computational tools to support clinical decisions, is well established. Third, and most importantly, the presence of AI does not replace physician accountability. When I make a clinical recommendation based in part on a Bioscope.ai analysis, I am accountable for the recommendation. The AI is a tool that I use. The physician-patient relationship and the physician's professional responsibility don't change because the tool is sophisticated. If you encounter any health service, AI-based or otherwise, where the physician layer is absent or seems perfunctory, that's a legitimate concern. The data is only as good as the clinical interpretation, and the interpretation requires a physician who knows you. If you want to go deeper on the whole genome sequencing question, I have a detailed blog post linked in the description that covers the technical aspects and the clinical aspects in more detail. In the comments, I want to hear, have you ever done any kind of genetic testing? What did you do with the results? And if you got data that confused you or you weren't sure what to make of it, drop that in the comments. Those questions are incredibly useful for future content. Subscribe if you want to keep following this work. I'm covering longevity medicine, precision diagnostics, and the intersection of AI and clinical medicine, and I post every week. And if you're in Atlanta and you want to actually see what a digital twin integrated longevity workup looks like for you specifically, the link to book at Pravida Health is in the description. See you in the next one.